In this session, we will be reviewing pediatric fractures and how these musculoskeletal injuries in children differ from those that you are used to in seeing in adults. The developing skeleton reflects the changing demands of childhood activity, and this is thus reflected in the changing proportions of trabecular and cortical bone as the child grows. Initially, in the newborn period, and shortly thereafter, the skeleton is very porous and resilient, much like a sponge, but shortly thereafter it develops into a much more rigid structure of the adolescent and certainly in the adults. And the fracture patterns are also reflected in this change in the skeleton development. So here we have examples of cross-sectional axial images of the forearm in a 2-year-old and a 15-year-old. These are T2-weighted fat-saturated images. And on the left, we can see that the arrow is pointing to a very vascular and porous cortex, whereas in the 15-year-old on the right, the cortex is much thicker and also less porous and thus more rigid. So musculoskeletal injuries in children really are bimodal. The lowest incidence is in the children who are less than 1 year of age. They have not yet started to bear weight or walk, and in this age group, boys are affected equally to girls. However, shortly thereafter, in the first year to second year of life, when the children start to bear weight and walk, the incidence spikes dramatically and is at its highest. Also, it's at its highest in the adolescent age range, which is not surprising as these teenagers become more active, are more actively involved in sports, and boys are affected more than girls more frequently. The upper limb is affected more frequently than the lower limb at about a 5-to-1 ratio, and this simply reflects all the falling on an outstretched arm or hand injuries. Not only do the fractures vary with age, but also the fracture healing varies. A femur fracture in a newborn can show substantial signs of healing in 20 days, whereas the femur fracture in a teenager may take up to 20 weeks to heal. So let's begin by looking at specific fractures in the youngest children. This fracture is called the plastic deformation, or you might have heard the term bowing fracture. This is where the bone undergoes a force of bending or compression, which is greater than its ability to recoil, so the sponge can no longer recoil, yet there are no radiographically apparent fractures. Although the cortex appears intact on radiography, it actually has sustained microfractures, and it's not uncommon to have the adjacent bone fractured. These plastic deformation injuries are most frequently seen in bones that have the thinnest cortices, such as the ulna and the fibula. Here we have two examples. On the left is a leg in a young child, and we can see that there is a radiographically evident fracture through the diaphysis of the tibia, but notice also that the fibula has a plastic deformation injury. Similarly, in the forearm, we have a fracture of the ulna, but there's a plastic deformation injury of the radius. Now, sometimes these fractures may not be so evident, as in the case of this forearm. We can see that there is an ulnar fracture. However, the radius appears relatively normal, and it's only in follow-up imaging when we see healing of the ulnar fracture that we also see periosteal new bone formation of the radius, indicating that it has sustained a plastic deformation injury. Now, if we go to a slightly older age range, where do the next kind of fractures occur most frequently? Well, if we look at the long bone, we see that the diaphysis has a very thick cortex. We look at the very short segment of the metaphysis, which is immediately adjacent to the physis, and then there is a vulnerable transition zone between the metaphysis and the diaphysis, which we have termed the metadiaphysis, and this is the site where fractures are most commonly visualized. The buccal fracture is a fracture that does happen at that metaphyseal-diaphyseal junction, where the cortex becomes thinner as it approaches the metaphysis and is more porous than its adjacent diaphyseal cortex. In this buccal fracture, those microfractures from the compression or axial load now coalesce into a buccal, but again, there is no radiographically apparent break. It's important to note that the buccal fracture has a very strict definition, namely it's a unicortical failure on the compressive side of bone, and it is considered an incomplete fracture. Again, we have an example of a thick diaphysis, a thinner cortex of the metaphysis, and then the intervening metadiaphyseal junction is where we see the buckling of the bone on the compressive side. This is another example of a buccal fracture. Now, if the injury has a force greater than that which produces a buckle, you may see a greenstick fracture. This similarly is a unicortical failure, but has a radiographically apparent fracture, and it's on the tension side of bone. It also is considered an incomplete fracture. Now, if you have a unicortical fracture on the compression side of bone, it is not a greenstick fracture, but simply can be called an incomplete fracture with cortical disruption. What about a toddler fracture? So what is the strict definition of a toddler fracture? Well, in fact, historically, a toddler fracture referred to any broken bone in a young child. So you can see that it is a very general term. We now refer to a toddler fracture as either a stress or an acute injury in the age range between 1 and 5 years, and the most common type of toddler fracture is the oblique fracture of the tibia. Children may present with a sudden refusal to bear weight. They may be irritable, more irritable than normal, and there may not be an obvious trauma or a known traumatic event. The bone may be locally warm and tender. On clinical examination, one way to determine if there is a toddler fracture is to very gently twist the affected bone, and this will elicit pain, similarly to twisting a towel. Also, pain may be elicited with a gentle dorsiflexion of the ankle. This too is a sign of a toddler fracture. On radiographs, a toddler fracture may not necessarily be evident at presentation, as in these frontal and lateral radiographs of the leg in a young child who stopped bearing weight without known injury. However, at follow-up at approximately 12 days' time, we can see that the fracture line is more evident. There is surrounding sclerosis of the spiral or oblique fracture, and there is periosteal new bone formation indicative of the fracture. Another common form of a toddler fracture is that of the cuboid. As the children start to bear weight, many of them are toe walkers, and there's a nutcracker type effect between the distal end of the calcaneus and the base of the 4th and 5th metatarsals. In this case, the cuboid develops an area of sclerosis at the base, which is the more common area, although occasionally it can be seen in the distal pole of the cuboid. Now let's move our attention to the physeal or growth plate fractures, clearly fractures which are seen only in skeletally immature or growing children. So if we take this example of a pediatric joint, which is modified from the late Dr. Wilkinson, we've taken a banana and sliced it along its longitudinal axis and are making a joint similar to this proton density weighted MRI image. We've cut off the tip of the banana and then reattached it with peanut butter. The bone is the banana. The tip of the banana is the epiphysis or the chondroepiphysis, which has yet to fully ossify. Notice that the peel of the banana or the periosteum does not extend to the tip. The physis is the peanut butter. Again, the periosteum is the peel of the banana. And then the picture wire represents a ligament, but it may also be a tendon or a joint capsule. So now imagine, if you will, that you traumatize this banana model of a pediatric joint. Well, in children, it's the peanut butter that will give before the bone with the surrounding periosteum, or certainly before the ligament or the picture wire. So physeal injuries are a point of inherent weakness in the pediatric bone and thus are commonly affected in trauma. Physeal injuries represent approximately 15% of fractures in children. The distal physes of a bone are affected more commonly than the proximal physes, as they are less protected. Most common sites of physeal injuries include the distal radius, the distal humerus at the elbow, the phalanges, and the distal tibia. And boys seem to be affected more frequently than girls, which likely reflects that their physes are open longer and they may be in more active athletic events. The description of the physeal injuries actually dates pretty far back, including a really comprehensive and remarkably accurate tome by Dr. John Poland, who was a British surgeon, and he published his work in 1898. Now, if we look at what he published, much of it is remarkably correct and accurate to this day. Since then, there have been numerous descriptions of different physeal classifications for injuries, but that which is most commonly used and most frequently recognized belongs to Drs. Salter and Harris, who were both orthopedic surgeons in Toronto. Now, their classification of physeal injuries is based on radiographic appearance and the risk for growth arrest and has undergone numerous revisions since their time. However, it is still largely used. And this was their landmark article written over 50 years ago that is still referred to. So in the Salter-Harris physeal fracture classification, this is the normal bone. What they term a type 1 is a strictly physeal injury. A type 2 is a physeal fracture which extends into the metaphysis and includes a small portion of metaphyseal bone called the Thurston-Holland fragment. Their type 3 fracture is physeal and then extension to the articular surface. And then type 4 is really the bad math. Between 2 plus 3 equals a type 4, and that includes both an epiphyseal and a metaphyseal component. Now, each of these fractures can happen in children, but there is an age differential of when it's more likely to see one or another type of fracture. If we look at the Salter-Harris type 1 fractures, this is typically seen in the youngest children, the neonates and infants, whose physes are much smoother in contour than that of the older children. And because the distal epiphysis may be still cartilaginous in these young children, these fractures may be overlooked or even misdiagnosed as dislocations. Older children can also have type 1 fractures, which are purely physeal, with an underlying physeal abnormality, such as in a metabolic disorder or a neuromuscular disorder, such as myelomeningocele. The good news is these fractures result in little growth disturbance. As we get into a slightly older age range, we can see that the physis is much more undulating. On your left is a young physis, and you can see that it's quite smooth, whereas on the right is a more undulating fracture in an older child, and so you can imagine how difficult it would be to have a fracture plane course just through the physis. The Salter-Harris type 2 fracture is seen in the slightly older age range, generally about 3 to 7 years, and this is by far the most common physeal fracture pattern. It is a result of a shearing or a twisting injury, and with the metaphyseal component, we term this the Thurston-Holland metaphyseal fragment, named after a British surgeon who did a lot of work with radiographic appearance of fractures. These are often easy to diagnose, as we see in this thumb. This is a Salter-Harris type 2 fracture. The same type of injury might result in an ulnar collateral ligament injury in an adult or a skeletally mature child. On your right is a Salter-Harris type 2 fracture of the distal radius with substantial displacement of the distal fracture fragment. However, these fractures are not always radiographically evident, as in this child who sustained a fall in an outstretched hand and presented with wrist pain. Initial radiographs were unremarkable, and then in follow-up with persistent pain, we can see the sclerosis, which indicates that there is a healing Salter-Harris type 2 fracture. Another patient sustained a knee injury, and there was a high suspicion for fracture, which was not seen on radiography, and so the patient underwent MR imaging, which demonstrates the Salter-Harris type 2 fracture. Now, moving on to the Salter-Harris type 3 fracture, we're getting into an older age range. These typically are seen around the time of physeal closure, so we are now getting into the adolescent age group. These fractures extend from the physis into the intra-articular region and may result in a step-off or a distraction at the articular surface. This is an example of a knee of a boy who sustained a knee injury, and he had persistent pain, so he underwent MR imaging, which is not necessary for Salter fractures, although in high suspicion cases is certainly quite helpful. And in his case, we can see that there is in fact a Salter-Harris type 3 fracture that does not show distraction or displacement of the fracture fragment. The juvenile Toddler fracture is an example of a Salter-Harris type 3 fracture, and this reflects the anatomy during physeal closure. In most bones, the physis closes from a central to a peripheral location. However, in the distal tibia, the physeal closure begins at the anteromedial portion of the distal tibia in what's known as Kump's bump over the medial talar hump. And because of this physeal closure pattern, a Salter-Harris type 3 fracture courses through the epiphysis, but always goes out laterally because that portion of the physis remains patent. So here we have an example of a classical juvenile Toddler fracture. Now, often these children may undergo CT imaging to evaluate the extent of distraction or step-off at the articular surface, with the rough guideline of approximately 2 millimeters being the difference between closed fixation or possible intraoperative intervention. Patient on the left shows no substantial displacement, whereas the patient on the right had greater than 2 millimeters of displacement, which brought him a intraoperative reduction in casting. The Salter-Harris type 4 fracture courses from the metaphysis to the epiphysis and similarly can result in displacement or distraction at the articular surface. And just like the Salter 3 injury, anatomic reduction is really imperative to result in a smooth articular surface to minimize the risk of growth arrest and subsequent osteoarthritis. An example of a Salter-Harris type 4 fracture, which often happens in the distal humerus or distal tibia, is the lateral condylar fracture of children. Now, interestingly, these injuries happen in slightly younger children. Here we have an example of the distal humerus, and we can see that the distal epiphysis is largely cartilaginous, but there is a small ossified capitellum. In a type 1 lateral condylar fracture, the fracture plane goes through the metaphysis, involves a portion of the physis, and extends into the epiphysis, but not all the way to the articular surface. A type 2 injury will extend all the way to the articular surface, but there is no substantial displacement. So these type 1 and type 2 fractures can be subtle on radiography, whereas a type 3 fracture has displacement of the fracture fragment as a result of a pull from the extensor tendons, and this generally is quite easily identified on radiography. This is an example of a lateral condylar fracture, type 3, where there is substantial displacement and distraction of the fracture fragments, and you can see abundant surrounding soft tissue edema. Here we have the cartilaginous epiphysis and the fracture plane, which is both metaphyseal and epiphyseal. However, sometimes these lateral condylar fractures can be very, very subtle. As in this example of a lateral condylar fracture, we have frontal and lateral radiographs, but the fracture line is not clearly evident or is relatively subtle. In this case, you may request shallow oblique views of the elbow, and the fracture fragment becomes much more evident. The triplane fracture also is an example of a Salter-Harris type 4 fracture with a sagittal epiphyseal component, an axial physeal component, and a coronal metaphyseal component. And all these components are more easily identified on CT imaging that also is obtained to evaluate the extent of distraction or displacement. And certainly 3D imaging is very graphic to show the sagittal component, the axial component through the physis, and the metaphyseal coronal component. Now, the final area I'd like to touch upon are fractures from inflicted trauma or child abuse. Dr. Paul Kleinman has done the lion's share of work with respect to classifying these child abuse fractures, and he has a system to classify these fractures according to their specificity for child abuse. There's a group of fractures which have a high specificity for child abuse. That is to say that if you see these fractures, the child should be considered abused until proven otherwise. The type of fractures which fall into this category include the classic metaphyseal lesions, or CML, rib fractures, particularly posterior and posteromedial, and then the S fractures, that is the scapular fractures, the spinous process fractures, and the sternal fractures. There are also fractures which fall into the moderate specificity group, such as digital fractures and vertebral fractures, and fractures which fall into the low specificity group but are common fractures but could have other etiologies, such as linear skull fractures or diaphyseal fractures. Now, if you are evaluating for child abuse, it is inadequate to do what we call a babygram, meaning to do a large portion of the body on one radiograph. It is inadequate to do a radiograph of entire limb. You must do separate radiographs for each body part. This will ensure that you're doing correct technique for that body part and that the beam is centered on the area of interest. Let's take a quick look at the classic metaphyseal lesions, or CML lesions. You may know these as corner fractures or bucket handle fractures. These are just additional names for these CML lesions, but they are all the same fracture. Here we have an example of corner fractures of the proximal tibia and a bucket handle fracture of the proximal tibia when it's viewed with slight obliquity. Diagrammatically, we can see these corner fractures are fractures of the metaphysis just subjacent to the physis, and as the fracture courses out to the periphery of bone, it's undermined by some bone, and so you get a little corner of osseous fracture fragment. Now, if we take this bone and oblique it slightly, or we oblique the tube, this peripheral fracture fragment then becomes a bucket handle similar to this. This is an example of a leg in a child who has a bucket handle fracture distally, has a corner fracture of the distal femur, unfortunately has also fractures of the proximal humeri, which are in various stages of healing. We can see corner fracture and bucket handle type appearance with callus formation. The forearm of the same child shows healing fractures of the radius and ulna, but notice also that there is a fracture of a different age, a buccal type fracture of the distal radius, and then a fracture of the acromion, which falls into that S category, a fracture of the scapula, and posteromedial rib fractures, all highly specific for child abuse. So with that, we'll finish. We have reviewed briefly some differences of the growing musculoskeletal system compared with adults. We've looked at the plastic deformation injuries which happen in the younger children as their skeleton is similar to a sponge, the buccal and the Toddler fractures, then the group of physeal or growth plate fractures using the Salter-Harris classification, and finished with fractures of child abuse. Thank you.